All of us, when we're young, start off fascinated by this world we live in behind our eyes that nobody else can see or touch or taste or feel. And as we get older and more mature, we realize that we have to rely on behavior to understand what other people are experiencing. And in fact, we have to rely on behavior to understand what we're experiencing too, it turns out. But let's talk about some of the sort of basic principles in history. This is a sort of a prose poem about the nature of consciousness that was used to open up the book The Origin of Consciousness by Julian Jaynes. It's a wonderful sort of meditation on what the heck is this thing that happens inside our heads that we can't really see for other people, but we infer happens for other people. And in fact, we infer it happens for all sorts of beings. Everybody's convinced that their cat or their dog has consciousness too, but we have no more way of knowing that than we do for each other. But somehow this intracosm is more myself than anything I can find in a mirror. It's myself of cells, it's everything and yet nothing at all. And what is it? Where did it come from and why? My interest in consciousness is rooted in trying to take care of patients and relying on what patients tell me about how they're feeling. And having to deal frequently with a discrepancy between the way they're behaving and the way they tell me they're feeling, or the circumstances of their life and the way they tell me they're feeling. So they may tell me about tragedies they've gone through over the last several months, and they'll say, "Oh, I'm fine. Everything's fine. Nothing's bothering me. I'm coping just fine." And so it's very, very hard for me to believe that. It sort of puts us in a corner when we're trying to have an accurate and honest conversation with patients. This is from the Greek mythologies. Antiochus was a crown prince of one of the Greek city-states whose mother had died young, and his father remarried when he was a young man to a woman who was only a year or two older than him. And he fell desperately in love with her. Her name was Stratonice, but he felt great guilt about betraying his father and being dishonest with his father and that sort of thing. And he fell into a swoon from which none could arouse him. And it sounds like he was in a depressed state for some weeks or months. And they called all the physicians from the local area and from other city-states to try and cure him, and no one could cure him. And one day, a physician named Erastratus happened to be palpating his pulse when Stratonice walked into the room, and his pulse picked up very, very quickly. And Erastratus very quickly figured out what was going on. But Antiochus still would not admit to his love for Stratonice. And Erastratus's solution, his cure, was to arrange for a comely young maiden to attend upon Antiochus. And within a short order, Antiochus fell in love with a comely young maiden. He regained his health and all was well. And the story sort of illustrates several things that often we're stuck trying to figure out what's going on with patients when they are reluctant to tell us what's going on. We have to infer what's going on from circumstances and their behavior, and occasionally, if we have that option, physiological changes that are going on in their body. But oftentimes we don't even have to get them to acknowledge what the problem is in order to solve the problem. If we can figure out how to arrange their life in such a way that they can recover. So my lifelong interest has been between psychological phenomena on the one hand and medical illness on the other. And the mediating factor there is, in most circumstances, almost all circumstances, emotion. It's the chronic and acute arousal of emotion that affects the medical phenomena that in turn influences disease progression. So There are the behaviors that are related to medical phenomena, like not taking your pills properly or not refilling your prescriptions. There are behaviors like substance abuse or alcohol abuse, smoking, exercising, or sedentariness. And there is this relationship between emotion and symptoms. In almost all circumstances, whatever illness you have, it will be worse if you are emotionally distressed in one way or another. It depends upon the illness. Some illnesses appear to be aggravated to doctors if you have anxiety, and others appear to be worsened by depression, or at least the suffering that the patient is going through is worsened by depression. In addition, there are all sorts of short-term biological phenomena that we know about, like sympathoadrenomedullary arousal, inflammation, immunosuppression, thrombogenesis, vasoconstriction and spasm, and even telomere shortening, which is a measure of cellular aging. It appears that even at the level of the genes or at the level of the DNA, there's damage going on over the long term with people who are under stress for long periods of time. So my problem is, can I trust self-reported measures of emotional arousal? Because what I'm interested in most of the time with most patients is trying to reduce the amount of emotional distress in their life. I think of this as density, which is the summation of frequency, intensity, and duration, but that's a technical issue that we don't need to deal with. It's just a question of trying to reduce how frequently people get angry, how long they stay angry, and how intensely they get angry, or depressed, or anxious, or whatever. And if we can do that, we seem to be able to have beneficial effects on things like heart disease. Chronic pain patients seem to do much, much better if we can successfully treat this problem, as well as a number of other conditions. So the paradox with consciousness is that science fundamentally requires consciousness. One of the fundamental needs that science has is for two or more people to agree that something happened, or that it happened in a particular way. So a star blinked off and on, or a particular chemical reaction turned green instead of blue, or that the gauge that we're looking at said 60 instead of 40. These all are subjective experiences, and if two or more scientists don't agree on them, we have a problem. We can't have science. It just cannot happen until we resolve this inter-observer disagreement. In psychology, for a long time, people struggled with the question was, does consciousness even exist, or is it an illusion in some way, shape, or form? Since no inter-observer agreement can occur, I can't tell if when I experience red, you're experiencing the same thing I experience as red. I can tell that we both agree this thing is red, but I don't know what red means to you, and you don't know what red means to me. Assuming that we're willing to accept that consciousness does exist, why? Why does it exist? What purpose does it serve? There's no Darwinian reason for understanding why consciousness would even occur. It seems more than possible that people could respond to stimuli through the biology of their nervous system and engage in adaptive behavior without any need for subjective experience. So why does subjective experience occur in the first place? And there are a number of theories or ideas about that. We'll talk about those a little bit. But we can infer the existence of consciousness from the fact that A, we experience something, and the behavior of others and the verbal behavior, including them telling us that they experience something. And of course, their pets experience something. But how big a nervous system do you have to have, or how complex a nervous system do you have to have in order to have conscious experience? Do we think that amoeba have subjective experience? They behave, they withdraw from painful stimuli, that sort of thing. So how complicated does the organism have to be to have consciousness? We can also infer consciousness from the fact that consistency of stimuli, such as light frequency, produces certain response patterns in the central nervous system, as well as verbal reports about what they're experiencing. The response of specific somatosensory neural cells, such as rods and cones in the eye, to a given physical stimulus. And we can, to some extent, manipulate apparent consciousness by manipulating awareness and attention. And we'll talk about some examples of that. This is Wilhelm Wundt. He is credited with being the founder of psychology because he founded the first administrative unit at the University of Leipzig in 1879. He advocated for what he called analytic introspection, which meant his assumption was analogous to the physical sciences, that you had to break consciousness down into its units in order to be able to understand how they related to one another, and created this experience we have. This turned out to be an enormous dead end. People would spend hours trying to analyze their consciousness into units. And within a very short period of time, people turned their back on that. I personally credit Darwin with being the founding father of psychology, because before Wundt even founded his lab, he wrote a tremendous book that's still worth reading called The Expression of the Emotions in Man and Animals, in which he talks about the behavior of emotional expression and how it's consistent, not only from human to human, but between humans and other mammals, and how it seems to be something that is part of our genetic heritage. So when Wundt sort of led us down a blind alley for a while, the reaction to that was to create behaviorism. Behaviorism was this sort of very concrete unwillingness to talk about mentation at all in any way, shape, or form. Certainly wouldn't talk about consciousness. And so for a long time, we thought about the brain as a black box, and you had stimuli going into the black box and behavior coming out. And we could count the behavior, and we could manipulate the behavior to some extent, at least in organisms like rats when they were running mazes and that sort of thing. And for about 40 or 50 years, this was really the dominant way of thinking about psychology. If you go back and read textbooks from courses back in the 40s and actually into the 50s, many of them would not even mention cognition or thoughts or feelings or beliefs or feelings. They would strictly limit themselves to stimulus response discussions. That turned out to not be adequate, because we discovered fairly quickly that the relationship between stimulus and response was more complicated than we thought, and that animals would develop expectations as a result of the reinforcement hierarchies we were giving them. And if we disappointed their expectations, their behavior wouldn't change back to baseline, it would actually get worse. They would withdraw from the experiment, that sort of thing. So what really probably forced the hardcore behaviorists to stop talking simply about stimulus and response was Roger Sperry. And Sperry was a psychologist at Stanford back in the 60s. And he got interested in patients who had intractable seizures and were undergoing commissurotomies. There's this band of tissue that joins the two hemispheres of our brain and does the communicating between the two hemispheres at a high rate of speed, enormous rate of speed. And the neurosurgeons decided, the drugs were not very good back then, the neurosurgeons decided that they could limit the severity of the seizures by slicing the commissure. But of course, that was a terrifying thought at the time, because it was a big band of tissue and it seemed to be doing important things. And everybody was sure that the damage that would be done by this surgery would turn out to really horribly disable the person. That turned out to be wrong. It turned out that when you sat and talked to these people after the surgery, you could hardly tell there was anything different about them, which was a surprise to everybody. Everybody thought this was very, very strange. And it was only when Sperry began doing some very carefully controlled experiments that it became clear that there was something very, very strange going on with these people. So this is an illustration of what a cerebral commissurotomy does on the left here. They slice this band of tissue that allows for communication between the two hemispheres. And what that does effectively is it means that if you center fixate your vision, everything that's on the right side of your visual field goes to your left occipital lobe, and everything on the left side of your visual field goes to your right occipital lobe. And they can't integrate. They can't communicate with one another because the commissure is gone. And Sperry would present these things, what we call tegistoscopically, which means he would have the patient center fixate. That you could actually check to see if they were center fixating. And then he would flash it at a high rate of speed. I think it was about 1/10 of a second, so that you could see only what was on the two sides of the field with the opposite hemisphere. So these people turned out to have some very strange behavior. If they were right-handed, their language would be localized to the left side of the brain. When the stimulus was presented to the left hemisphere by being in the right visual field, the person could tell you what was presented with 100% accuracy. However, when the stimulus was presented to the left visual field and to the right hemisphere, they couldn't tell you. They would say that they hadn't seen anything. The weird thing was that if you gave them a piece of paper, they would then draw the thing that had been named in the left visual field. So what you have here is a person who seems to have two brains operating within the same head at the same time. And it's that those two brains are both taking in the information. They both understand the information well enough to be able to respond correctly. But one of them is aware of what's happening and one of them is not. So you have, for all practical purposes, an unconscious part of the brain and a conscious part of the brain. And there were a lot of psychoanalysts who got very, very excited about this and said, this is what we mean by the unconscious brain, but that's probably an overgeneralization because these were not normal brains. These were people with many years of intractable seizures who had undergone this fairly massive brain surgery. And it would be an error to think that this is the way a normal brain works. And besides, you know, in most of us, the great cerebral commissure is still intact, so we're still communicating between these two parts of the hemisphere. So is this really the way unconsciousness works in normal people? Almost certainly not. But it does provide us with an example of two apparent complex psychoneural systems in the same head responding in appropriate ways, in reasonably complex ways, and one side being totally unaware of, or at least the person reporting no awareness of. So people, what would happen with many of these tests that Sperry would present to the patients was that not only would the person respond appropriately with the left hand, but if you asked the person why they responded that way with that hand, they would make up a story. And it was almost like they had no cognizance or no awareness at all of what was going on in the right hemisphere of their brain. So this is called confabulation. We see this a lot in people who are dementing. They make up stories to explain things that they can't otherwise explain. They would manufacture a plausible explanation. So for example, if you presented a picture of a fire to the nonverbal hemisphere, and the contralateral hand would point to a picture of a fire truck, if you ask the person why the hand had responded in this way, the patient would say something like, his son likes fire trucks, so that's why I pointed to the fire truck, with no mention at all of the stimulus that had set him off. When presented with a picture of a nude, patients would blush and become flustered and report not seeing anything, but then say something like, this is a really strange machine you have, Dr. Sperry. What's going on with this machine? So the implication here is you have complex processing and responses occurring in the nonverbal hemisphere without any apparent awareness, or at least awareness that the patient is able to report to us. Sperry got the Nobel Prize, by the way, and I think it was 1980 for this work. This is Lauren Weiskrantz. Weiskrantz was interested in people who had damage to the primary visual receptive fields in the back of the brain here in the occipital lobes. And again, he would use a tachistoscope. They would map out the visual loss of the patient's visual fields, depending upon where the damage was. And they would tachistoscopically present a letter or some other stimulus. And the patient, theoretically, they would give them multiple choices, let's say 4 choices. So theoretically, the patient should get it right about 25% of the time, but they would get it right like 40, 50, 60% of the time, which statistically is not supposed to happen. So it appeared that there was non-conscious processing going on. The person would say, I see nothing, but when they asked them to guess which of these stimuli was related to whatever they had shown, they were able to get it right at better than random chance. And so when you ask the people, well, why did you choose that choice if you saw nothing? They would say they were just guessing, or they had a hunch or a feeling. And for someone like me, it begs the question, is this what we mean when we talk about intuition? Are there tracks or systems in the brain that allow us to take in information that we're not aware of and to have some kind of better than random chance at understanding what's going on? There's a lot of other medical syndromes that sort of provide some insight into consciousness, including the major psychoses, delirium, dementia, schizophrenia, and bipolar disorder. In the case of schizophrenia and bipolar disorder, of course, you have hallucinations and delusions. In the case of delirium, you have this very interesting mental state. We call it an altered mental state, which can range from anything to being unconscious and difficult to arouse to being agitated and flying around the room. People typically during delirium are sort of slowed and confused. There's a waxing and waning of arousal and attention, so they'll be relatively lucid at one point in time, and an hour later they'll be very confused. It does show up on an EEG. It's easy to measure delirium on an EEG. 9 times out of 10, you can pick up what's called slowing. So instead of having a resting rhythm rate of alpha, which is about 8 to 12 hertz per second, they would have a resting rate of, say, 3 to 7 hertz per second. And so it's measurable in some objective sense. In addition, we have things like Charles Bonnet syndrome. Bonnet syndrome is when you have peripheral damage to the visual nervous system, and people will develop what are called Lilliputian hallucinations. They will see little people or little animals around the corner of the room. For some reason, it's always in the corner of the room. But what's curious about these hallucinations is that they're ego dystonic. And what we mean by that is the person knows they're hallucinations. They're able to say, that's not there. I'm seeing things that aren't there. You never see in schizophrenia. The schizophrenics always say this is real, unless they're afraid to tell you that they're even happening in the first place. So there's a form of hallucinations here where in our conscious minds, we're able to tell that's not real. There's something different about it. We have the phenomenon of Capgras Syndrome, which if you remember the old movie, The Invasion of the Body Snatchers, it's sort of a classic example where people look at individuals they know and they say, yes, that looks like my brother, but that's not him. He's faking it. That's someone who's faking it. Sometimes called imposter syndrome or pod people syndrome. But here, the experience is egosyntonic, meaning that the person believes it's real, that they're right about this. And it implies that there's something intrinsic in the way our brains work, that objects around us that we're experiencing consciously are familiar or not familiar. And the lack of this, whatever it is, this lack of familiarity is the central deficit in Capgras syndrome. There's also a number of weird syndromes like Cotard syndrome, where the person insists they're dead, even though they have a pulse and they're walking and talking, or Fragoli syndrome, which where people think that multiple people are actually the same person, and they're just changing their looks and coming in and out of the room at different times. Again, these are weird experiences that we have a hard time understanding or localizing in the brain. A more common phenomenon is homomonous hemanopsia, where the visual tracts to one side of the brain are damaged. You get unilateral loss of vision, but what's interesting about it is that the person isn't aware of the loss of vision. So they get up and try and walk, and they're constantly bumping into things on the, say, the left side or the right side of their visual field, and they have a terrible time adjusting to it. There are some patients, interestingly, who have what we call theory of mind or metacognition. That is, they're people who premorbidly think about thinking. They're sort of what we call psychologically minded people. They seem to adjust better to this. It seems to be easier for them to understand that they have this deficit, but others have a much harder time. There's the phenomenon of locked-in syndrome, where if you have a massive damage to the reticular activating system in the base of your brain, some people are left with no ability to move anything in their body except their eyes. They can move their eyes up and down. And so you can communicate with them by having, say, one eye movement being yes and two eye movements being no. And the question is, are these people conscious? I've seen 2 or 3 of these people, and what's often hard is convincing the family that the patient's still alive. We've had two cases I can think of where the family was convinced that he was brain dead and that we ought to just let him go and not try to keep him alive. And we had to spend a lot of time with the family trying to get them to understand that these eye movements were meaningful and that they actually are able to communicate. The longest any locked-in syndrome has been known to live is 17 years. It was in Italy, and some courageous fool actually administered a Minnesota multiphasic inventory, which is like 365 questions, yes, no questions, which must have taken days to do. But what was interesting was that the patient reported that their life was kind of interesting, and they had, cool things to do all day, and that sort of, which seems very, very bizarre to us, but apparently indicated that this person had adjusted as well as could be expected after 17 years in this state. And then there are things like anesthetic awareness. A small number of patients who under anesthesia will actually be able to recall events during the surgery. They'll actually be able to recall conversations that have gone on around them. And some of these people develop PTSD. For most of them, the pain is adequately controlled, but some of them say it's not after it's over. But it's a terrifying thing to think about experiencing. And then there are the various conscious phenomena around sleep that are a puzzle. Sleepwalking, narcolepsy, cataplexy, that sort of thing. So the nature of unconscious states is that some of them are due clearly to the way our neurology is arranged. Phoneme recognition would be an example. We can manipulate the sounds that you hear so that the same sound can produce the experience of a D, a T, or a B, depending upon the context in which you hear it. But you're not aware of that. It's exactly the same physical stimulus, but it produces these different experiences because of the other sounds around it. And of course, this is not something we do consciously. This is something that our brain does automatically. This probably includes early life amnesia. Very few people claim they can remember much before about age 6. The brain doesn't seem to be evolved to actually recall things. People will tell you they can remember things before 6, but actually we know we can implant memories in people about things that happened to them in their early life. We can actually present conversations in which we talk about them getting lost in a mall, say, and if the people around them all agree, oh yes, I remember that, At some point, they start to say that they remember being lost at the mall, not just that people have told them they were lost at the mall, but they remember this. A second phenomenon is the attention or figured ground phenomenon. You're not aware of the sensations from your left foot right now until I bring your attention to it, but your brain is. Your brain is taking in information from every inch of skin on your body right now. But of course, you're not attending to it. Your attention is focused elsewhere. And you couldn't function probably if you were aware of it all. This has been the basis for some very interesting and provocative testimony or research on eyewitness testimony by Elizabeth Loftus. Loftus has done some very interesting studies that really raise the question about how much can we trust people who are telling us about a crisis that occurred. So, for example, one of the best known examples she used was someone where there's a videotape of a cafeteria, and over on the left side of the cafeteria, two people get into a fight and start throwing dishes around and punching each other and that sort of thing. And what's interesting is that on the opposite side of the tape, a man in a gorilla suit walks in through a door, walks across about half of the screen, and then walks out another door. And nobody remembers the gorilla. It's very, very rare for people to notice the gorilla, which raises all sorts of questions about when people are telling us about, shootings or auto accidents or other things, can we really trust what they're telling us? Another phenomenon is automatization, which is overlearned disattention. That is, we learn to attend to those things we have to attend to and to disattend the things we don't have to. About a third of people, if you survey them, will tell you that they have had the experience of driving from point A to point B. And after they get to point B, they say, who drove here? I don't remember driving here. And it's a little scary the first time or two they realize this. But what's happened is that the driving is so overlearned and so automatic that their brain is on what's on the radio or a conversation they had or whatever. If you take an engineer and an artist and you have them ride across a bridge, they will remember very different things. Their attentional bias for what's interesting to them about that bridge is going to be very different. And then there are the social influences, which we'll talk about at a little more length. So this is an experiment done back in the 1950s by Solomon Asch, in which he would set up, say, 6 or 8 college students in a line, sitting in a line. He would show them these 2 lines, A and B, and he would say, which one is longer? And what the subject of the experiment didn't know was that all the other college students were Confederates of the experimenter, and he would be the last one in line. It would be set up so that he would be the 6th or 8th person. Everybody else would say, well, A is longer, A is longer, A is longer, A is longer. And about a third of people would go along with it and say, A is longer. And what's interesting is that when you debrief the subjects, most of the 1/3 will say, no, I was just going along with everybody else. But a few will still insist that A is longer. And so the question is, what are they subjectively experiencing? Are they somehow influenced by their social environment to perceive things differently? There are a number of reasons for people suppressing or denying emotion and perhaps deluding themselves about emotion. Things like shame, guilt, embarrassment, mistrust of the experimenter. It often takes a while to build rapport with patients and get them to the point where they're willing to trust you. Some patients hate acknowledging that they're not in control of themselves. They hate being vulnerable. Avoidance of conflict. It's very common for people who've had problematic childhoods to learn to not express or acknowledge things like anger or sadness or fear. It's adaptive for them. If you express these things in the presence of an alcoholic, you're liable to get beaten. Surreptitious arrogance. Some patients will say, this isn't relevant to why I'm here. I don't know why the doctor's wasting my time with this. I'll just say, no, I don't feel this. Avoidance of labeling or dismissal. People who have lots of symptoms, they have what are called somatoform ailments. are afraid of getting labeled a crock or a gomer, and dismissed from the doctor's presence. And then there's adaptation and automatization, this learned or acquired disattention to emotion. We have all sorts of other terminology we use for this sort of thing. So the data we have for trying to evaluate consciousness include what the patient says. Technically, in psychiatry, this is referred to as mood, the nonverbal behavior that the patient expresses, which technically we refer to as affect. The old days, we called it leakage. We have the biology of the emotional response, which we can study in labs, but which are impossible to study for the most part in clinical settings. And then we have knowledge about the stressors or events that are happening to the patient. And it's the discrepancy between what the patient says they're experiencing and these other sources that make us think about denial, or we have to look harder at what's happening to the patient. So as I mentioned before, I'm interested in anger because of its strong relationship to predicting heart disease. I learned a long time ago that I never ask my patients about anger. I ask them about frustration. Lots of my patients are frustrated. None of them are angry. And we devised a measure many years ago, back in the 80s, I think, no, in the 90s, I think, where we took a whole, every symptom of stress we could think of and put it in a checklist and had people rate the frequency of it. And what's important about this measure is that it has a directly parallel version that we give to the spouse. Or if we don't have direct access to the spouse, we actually put it in an envelope that's stamped, it's self-addressed to me, and with some written instruction to the patient. And we tell the patient, you know, it helps us to have another person's perspective on how you're doing. I don't know you that well. We've only met for an hour or so here. Would you please give this to somebody who knows you well to send back? And most of the time, they'll give it to their spouse. Sometimes they won't. They'll give it to somebody else who they presumably think knows them well. And we begin to look at the difference between what the patient tells us and some third measure and what the spouse tells us in some third measure. So this was, I think, our first attempt at this, where we were interested in the question of how do these items correlate or co-vary with the Jenkins Activity Survey. The Jenkins Activity Survey was the first questionnaire that measured type A behavior and predicted heart disease. And as you can see, most of the measures did not correlate with the Jenkins Activity Survey. And the ones that did tended to be measures of anger. So feeling angry, wanting to yell at someone, feeling pressured or feeling under stress. But look at the correlations with the spouse-friend measure. Almost all of them are strongly correlated. Some of them just mind-blowingly so, like 0.6, 0.7. We never see those kinds of correlations in the behavioral sciences. And then we ran what's called a partial correlation, where we factored out the influence of the spouse-friend, or pardon me, of the self-rating, and then tested the residual relationship with the spouse-friend. And again, these all stay very strongly related. So what this implies is that whatever the Jenkins Activity Survey is measuring, the spouse is a better source of information than the patient. Unbeknownst to me, when I started this work, there was a doctoral dissertation out of Wayne State, actually, by Robert Neep, who's in private practice around here. And he looked at patient ratings and spouse ratings and their covariation with thallium stress scans. Thallium is used to measure energy uptake in the heart in patients who are suspected of heart disease. And you can see that the spouse ratings covary with the abnormal thallium stress scans. The self ratings do not. Siegman actually replicated this a few years later. He's at the University of Pittsburgh, or he was at the University of Pittsburgh. I'm not sure he's still there. And again, found that what the spouse told us was related to abnormal thallium stress scans. What the patient told us was not. We looked at patients who went through our cath lab and asked the question, well, does self-rated measures of stress relate to how severe the coronary disease is. When docs are rating these scans, basically what they're looking for is how many of the arteries are blocked. And we found that, first of all, depression was the best predictor of severity of coronary disease. But self-reported depression had no relationship. Spouse-friend reported relationship did, which seems to be the pattern that we see over and over again. Either the self-rating is non-related or is weakly related to the measure we're looking for, but the spouse measure is better, it's stronger. And the denial measure, which is the difference between what the spouse and the patient tells us, is the strongest predictor of all. Interestingly, in this sample, unprovoked nocturnal awakening, which is a symptom of depression, is also strongly related. And frequency of suicidal ideation was negatively related. That is, people with more severe disease reported less suicidality than patients with low coronary disease. Again, which looks like denial to those of us who are interested in how patients are doing. We followed this sample up 5 years later and asked the question, who's dead? And what predicts who's dead? And what we found was that hypertension, being a baseline smoker, and having diabetes were all predictors of who was dead after 5 years. But the strongest predictor far and away was denial of anger. There was about a 4.5-fold increased risk for death. Other things that usually are predictors of mortality, like age, history of hypercholesterolemia, and the severity of the coronary disease were also predictors, or are usually found to be predictors. Were not strong enough in our sample to reach significance, and were, again, far outclassed by denial of anger. We looked at age at onset. Age at onset is a predictor of disease severity. The earlier you get your disease, the earlier you are to die. And what we found was that self-ratings for males correlated with how early people got their heart disease. But far and away, the strongest predictor was spouse ratings, and particularly anger, again. Interestingly, for females, the relationship was, if anything, negative. Found no relationship that was detectable. After this work, we got interested particularly in the difference between the sexes. We looked at males and females for the 3 emotions and found that denial was far more common among males than females, and particularly anger again. To a lesser extent, anxiety, but anger was, again, the strongest correlate with denial. We looked at denial's correlation with coronary artery disease. And again, this is a male sample. There's this dose-response relationship. The more severe your disease, the more denial the people displayed. And again, it was strongest for anger rather than depression or anxiety. We also got interested in people with syndrome X, or what's called atypical chest pain. There are people who have no detectable heart disease but have lots of chest pain, and they scare the docs until the docs get the workup done. And what correlates with syndrome X, as we predicted actually, was depression and anxiety. Depression and anxiety are strong correlates of all sorts of measures of pain, but particularly chest pain. And treatment of depression and anxiety is actually the most effective way of treating this problem. I had a student who was interested in migraines, and she looked at self versus other. Negative, NA stands for negative affect here. If you look at the sample as a whole, it looks like the other measure is correlated with number of migraine days and pain severity. But when she breaks it into males versus females, it's primarily females, interestingly, who are denying negative affect. So in this disorder, the genders seem to be reversed. It's females who are denying or minimizing the amount of distress they're experiencing. We suspect this is true for a number of syndromes, but we haven't studied them. And we're hopeful that somebody will pick up this work at some point and start looking at some of these other syndromes. I think this problem accounts for why docs are so bad at recognizing emotional distress. I think I've shown you this slide before. If docs were good at this, at detecting depression, this is the Beck Depression Inventory. These cases should be clustered in the lower left or the upper right. These are false negatives. These are false positives. So what you have is, because patients are minimizing the amount of distress they're experiencing, docs are missing it altogether. You know, the average doc spends like 20 minutes at most with a patient a day, and frankly lacks the patient and patience and experience to actually evaluate this problem. But on top of that, what makes it difficult for them is patient minimization or denial. Recommended readings. So that's the sum total of my interest in consciousness. You'll notice here I wrote a paper in '85 on this topic, and frankly left it at that point and just said, well, how well can I measure this thing? Any questions?
Yes. Can I ask a couple of easy questions?
Sure.
Okay. First one is you gave that wonderful example of the two lines, A and B.
Yeah.
And you seem to suggest that an awful lot of it was people responding to peer pressure. How much of that would relate to the way folks, particularly Republicans, relate to the election outcomes, or January 6th, or any of the other rather bizarre conclusions that we seem to see?
Well, I suspect a great deal. I mean, I think it was interesting. If you remember the first vote on Lynn Cheney, it was like a 70-30 vote to keep her as the representative for the Republicans in the House. But it was an anonymous vote. Nobody knew who was voting and who they voted for. But when they made it public, when McCarthy made it public, nobody raised their hand for her. So I got to think that you know, this kind of social pressure is enormous, even for people who you would think would be immune from this, who would, you know, be mature enough and principled enough to vote their conscience.
Thank you. The second question is, denial of anger seemed to be an enormous effect on folks getting heart disease and all the rest of it. What's the alternative to denying the anger? What do? Go beat up your wife, or what?
Well, that's a start. No, obviously we don't encourage people to assault human beings as a way of coping with their anger. We spend a lot of time in therapy talking about, you know, why are you angry? What is it that sets you off? And how are you different from other people? Why are other people not so angry as you? And of course, there are roots of this in genes. As near as we can tell, about half of what determines your crankiness or your irritability is genes. But some of it has to do with the way you're raised and feeling defensive and that sort of thing. Some people, you know, hear criticism constantly. Other people are able to hear criticism and say, yeah, maybe there's something to that, and I should change the way I'm thinking or doing things, that sort of thing. And so for most people, if their anger is really out of control, we have to ask the question, are there things aggravating it? So what aggravates it? Poor sleep, alcohol or drug use, certain particular drug use. We encourage people to stay away from it. When people are acutely angry, if they're in danger of doing something that we consider maladaptive, like yelling, screaming, fighting, throwing, etc., we encourage them to just walk away until they calm down and spend some time reflecting. There's a whole sort of semi-mystical methodology for calming yourself that has to do with what's called mindfulness or self-hypnosis or meditation. All of these things seem to be helpful for people who have problems with this issue. I got to tell you, when I was working with these people in the early days, I had a friend at Mass General who I would visit with from time to time. And he talked me into trying low-dose SSRIs. He said, you got to try these drugs. And I said, these drugs are for depression. They're, you know, and at that point, I don't think they were even approved for anxiety. People were just starting to experiment with anxiety. He said, try them, try them, try them. And so I had a couple of difficult cases where I wasn't making any headway. And I said, okay, I went and twisted the arm of my psychiatrist and said, I want you to try this patient on low dose citalopram. And within a month, he was a different human being. I mean, it was astonishing. And his wife actually called me up and said, thank you, thank you, thank you. Don't take him off that pill. So ever since then, I've become very, very encouraged about the role of these drugs. And as I showed you, I think the last time I talked, it looks like they reduced the heart attack rate by about a third. And frankly, I think that the sample they used in that study weakened the test of their hypothesis. I think it'd be even stronger if they'd taken a general sample rather than they pre-selected just for depression.
Does the treatment last? I'm thinking about those experiments with LSD and I've lost his name for the moment, the really famous guy that wrote the book of my wife thinks I'm a hat, or I think my wife's a hat.
Oliver Sacks.
Yeah. And he went through all this LSD with these really, really withdrawn people, and it worked miracles for a little while. And then it went.
Well, that's a whole nother topic probably. People are starting to experiment with using those drugs again for intractable conditions. But these drugs this is a very different class of drugs. They work differently in the brain as far as we can tell. The effect, as far as I can tell, seems to be lifelong, as long as people stay on the pill. They do have contraindications and side effects to deal with, but there's actually some evidence now that these drugs reduce the likelihood of people getting hospitalized for COVID. Don't ask me how that works.
Thank you, Mark.
I have a question too. Can you hear me?
Yeah.
Yeah, I'm Booker's wife, and thank you for suggesting he not beat me up if he's angry. I really appreciate that. First, I have a comment. And when you talk about women and anger and women and pronouncing their feelings, I was raised in a generation where women just have to be more submissive to their husbands and nice to men all the time, and just, men are the rulers. And I mean, it was a terrible way to grow up, but that was the message I got. And I don't know whether that correlates at all with any of your research. Okay, my two questions, and you had a fascinating talk. One of them is you talked about the difference between an engineer and an artist going across a bridge and seeing a different world. You said they just noticed different things, but is that do engineers have a mentally different frame of mind than artists do? I mean, what do they see the world in a very different way than artists?
It's an interesting question. I'm here in Detroit, so we're surrounded by auto engineers here, and my impression, I've never seen any studies specific to engineers. Let me start by saying that. But they are sort of pragmatic, externally oriented people on average, and rarely worry a lot about how they're feeling or thinking, or other people are feeling or thinking. They're just practical, right? That can cause problems in relationships, and sometimes we have to sit down with them and say, okay, let's think about how we're different from somebody in your life who seems to be doing better in dealing with their children or whatever. And some people are able to do this, some people are not. You know, I do think that we tend to be drawn to work that feeds our talents, you know. Surgeons are different from psychiatrists. Internists are different from pediatricians. You know, on average, I think that people who are drawn to engineering tend to be different from many of us.
Because their brains are different, or because they.
So is there a genetics to this? I don't know.
Yeah.
That would be an interesting thing to study.
Okay, and I have one follow-up question. You also talked about being raised by an alcoholic mother or father, and
Right.
how you have learned to fear some things. Can you elaborate on that a little bit?
So if we study people who have difficult childhoods like that, and we look at them, you know, at age 10 or 12 or 20 or 30, they have different life trajectories on average. We're talking about overlapping normal curves here, but on average, people who grow up with alcoholics, and it depends upon the nature of the alcoholism. So some alcoholics are withdrawn, some alcoholics are angry and verbally or physically abusive, some alcoholics abandon the family, that sort of thing. And depending upon the nature of that relationship, people do tend to show different ways of adapting. So they may have trouble with anger. They may have trouble with trusting other human beings. I've seen many alcoholics who are overly sensitive to the use of alcohol by people around them. So they may have a spouse who has a drink once a week, but it makes them very anxious if their spouse has a drink. Because
I'm talking about the child rather than the alcoholic.
So, yeah, so am I. I'm talking about
Okay.
I'm talking about the child who in later areas of their life typically will show residual effects of the alcoholism. And it can take a number of different patterns, but there's sort of a modal, I don't know, half dozen different ways of people dealing with alcoholism. Some of them become alcoholics, some of them have trouble with relationships, some of them have trouble with self-control of anger and that sort of thing. Some will appear depressed. Some of them are sort of vigilant and anxious. It's like they're waiting for the world to fall apart. There's a not entirely disentangled question about, do these personality styles predispose people to alcoholism? Or is this simply the effect of the early life environment? And the answer almost always is it's some combination of the two that we ill understand, frankly.
Thank you.
So if I could interrupt a minute. You mentioned the telomeres, and as I recall, we genetically have telomeres that vary in size as part of our what's inside us. And the ones that are short usually are predictions of shorter lifespan. So it would seem that whatever can actually, what you were talking about, shortening them even beyond the point that they started out at genetically, is a predictor of a lifespan for that individual too.
Yeah.
And the other thing, just as a point of study, my husband's an engineer. I'm much more on the artistic side. And we often can look at something and see it differently.
Right.
Not necessarily a bad thing, though. It's just, I often say, but can't you see? And he says, that's what I see is this. And, you know, I grew up with a father who was an engineer, so I guess I just was used to that. But it's very interesting that you brought up that contrast.
Yeah. Well, let me mention about telomeres. Telomeres have been studied in children who have had abusive childhoods versus those who have not. And the telomeres of children who have had abusive childhoods are shorter on average. And I'm no geneticist, but my understanding is that the length of the telomeres at the end of your DNA are a reflection of turnover of the DNA. So if you've had to replicate the DNA a large number of times, you have shorter telomeres than if you haven't.
Right.
So it seems to have something to do with cellular aging, and frankly, my understanding of all that is very limited. But the fact that it co-varies is suggestive that it's causal. You know, nobody obviously has done a controlled clinical trial to demonstrate causality, but that's that seems to be what we know at this point.
I'm going to jump in here. I've been waiting for a few minutes here as my hand raised, which not everybody has seen. Mark, when you talked about early life amnesia and the assertion that after age 6, people have, as adults, don't really remember anything prior to that. And this all goes to the whole issue of continuity of consciousness. What's the data on that? Because within my family, I have a brother who insists he remembers what he did at 3 years old. I have verified proof of something I did at 4, which could not have been done at any other time. So 6 sounds like a really old age. Yeah,
well, like everything in behavior, there's probably a spectrum here, but the best work, or the most interesting work to me on this, was done by a woman named Linda Williams at the University of New Hampshire. She went back and dredged up ER records on children who had been sexually abused from 20 years before. And she found several hundred examples, and then she traced these people. She tracked them down and asked them, you know, were you ever sexually abused? And 37% of the people where there was objective, verifiable information, so it was either observed by a reliable other, like a parent or an authority figure, a teacher, or whatever, or there was actual physical damage to the genitals of the child. 37% had no recollection, but that 37% tended to have one of two or both characteristics. One was before age 6, it happened before age 6, and the other characteristic that they tended to have was that the family tried to keep silent about it. They wouldn't talk about it. They pretended it hadn't happened, and they sort of sucked the child into this collusion that there had never been any problems and that sort of thing.
So it's a pretty specialized population. So I think I'll do a little research on my own for just sort of general, normal kind of experiences.
I mean, the other thing that was interesting about this sample was when they were told, you know, we have documentation here from 20 years ago that this happened to you, none of them said, oh yeah, now I remember. A few of them, a number of them said, well, that explains things. That, you know, why am I this way or why am I that way? Why do I have trouble in my relationships with the opposite sex? Why am I anorgasmic? Why, you know, do I have dyspareunia or some other disorder?
Okay.
Okay, I have some questions actually.
Yeah.
I want to follow up with one thing that Booker asked earlier of you, which is about the behavior of some of the congressmen that we are seeing today. To what extent could we attribute some of the things that you're talking about versus plain lying?
Well,
like the congressman they were showing today, who's talking about, oh, this, look, if you didn't tell me it was January 6th, I would say this was just an ordinary day with visitors going through the statutory hall. And
right.
They were tourists. They were all tourists.
Yeah.
That's what they're saying now.
So now you're talking about a real specialized population, see?
Yeah, they were tourists, that's all.
Yeah, they were tourists, right? They're saying that, but they knew because they're showing the picture of the same congressman who's claiming they were tourists.
Yeah.
You know, hiding or trying to hide behind or trying to hold. Actively trying to thwart them coming into that hall, pushing. So he knows. So should I think of explanations of some cognitive dissonance, or should I say, oh no, this person is simply lying?
Well, yeah. Okay. So,
Yes.
so the line between lying and self-delusion is not necessarily an easy one to draw.
Yeah, that's what I was asking for. You said it very nicely. Where is that line?
You know, when I listen to what's his name, the guy from Wisconsin, Johnson, Senator Johnson. Have you ever listened to this guy? I think he believes what he's saying, but he's off the wall. I mean, he's another one of these guys who, you know, thinks they're all patriots and we should applaud what they're doing, and you know, any good American should be out there trying to take down Mike Pence or whatever. And so is that guy lying, or is he deluded in some way? I suspect he's deluded. I don't know.
No, that guy is, yeah, Johnson seems to be deluded. I mean, one could think about his behavior as delusional.
Yeah.
But I was talking about this other person. I don't remember this congressman's name, but he's been talked about. There's the most famous is the one who was saying that they were just tourists.
Right.
And he is the one who the cameras were showing today, how he was pushing against or trying to hide against the wall or something to be away. Another shot where he was pushing against the door to prevent the crowd from coming in.
Right.
So I don't think in that I could, kind of say that this person is deluded. I think at some point, I don't know where, it moves over to plain lying.
Yes.
Yeah.
I had another question
Harold
actually,
has a
which is from a different aspect of this. Also early in your presentation, you were talking about the behavior, the emotions. I want from your perspective, how do you distinguish between emotion and thinking?
So emotion is typically falls in with they're considered to be based on various types of evidence, 6 or 8 major emotions. And there are a constellation of biological responses that go along with each of these. And thoughts typically will or will not elicit emotion. So again, so it's hard to disentangle these two sometimes. But for example, a colleague of mine who used to be at UC San Diego used to travel around the country with a videotape of a patient he was seeing who he had hooked up to an electromyogram and a cardiac machine. And he would ask him, you know, were you upset when you found out that your wife was screwing your best friend? And what would happen, of course, is the cardiac measure would go through the roof, blood pressure would go through the roof, that sort of thing. But if you saw this guy, you would not guess at all that he was upset. He was totally calm sitting there. And he'd say, yeah, you know, the first time I was upset, but after that, I figured, you know, she's just not in love with me, and you know, he's a bastard and that sort of thing. But the overt behavior, the nonverbal behavior that was manifest to those around him was totally absent, and it was stunning to watch it. I mean, it's just, you can't believe that's going on, but it probably goes on all the time in therapy when we're sitting and talking to patients about upsetting things.
So when you want people to talk about their emotions, you don't want them talking. You want to be making those physical measurements. Because if they're talking, how's that distinguished? Or is it, that's where lying, or that's where that's where I was my confusion.
Yeah.
Because I have often been asked, how are you feeling? And if I would start saying anything, they say, no, but you're thinking. You're not telling me how you feel.
Right.
And I cannot tell you the difference.
Are you an engineer?
No, a chemist. Okay.
Chemist, almost as bad.
Almost as bad. Okay.
when we're sitting and talking to patients and trying to figure out what's going on in their life, it's not practical to hook them up to machines and to try and measure these things, first of all. And secondly, many of the patients refuse to do it. They don't want to do it. So we have to sit there and impute meaning based upon events that they're telling us about, or events that we can infer, and based upon nonverbal manifestations. And what happens over time is usually in a first session with a patient, the patient will look very calm, they'll be on their best behavior. And that as they trust us and become more relaxed, they begin manifesting how they're feeling. So for example, I had an anorexic one time who whose mother was resisting her athletic interests, and she felt trapped in this small town with her mother. And when I would try to get her to talk about what that must have done to her, because it was pretty easy to infer that she would feel frustrated or angry about that, she would sit up in her chair, cock her head to the side. This is automatistic behavior. Cock her head to the side and say, well, I'm a Christian, and Christians don't believe that it's okay to, get angry about other people's behavior. Or she would say something like, it's best just not to dwell on it. And after about the third or fourth time she did that, I asked her, this is one of the techniques we use, I asked her to just be quiet and close her eyes and sit still. And what happened was she just sort of crumped in the chair and started crying and talking about her frustration with her mother. And that was the first time she'd been willing to talk to me about it. And so that kind of nonverbal internal attention seems to make it easier for people to recognize and experience and talk about what they're going through.
Okay.
Got any more hands up?
Yeah.
Harold?
Yeah, just Mark, that was just fascinating. I think I may now know a little bit more about consciousness. But your questions of essentially what people feel and or what they experience, I'm wondering because there was a very recent study where they think they know why LSD may produce these experiences, that normally how we experience something is mediated by inputs and past experience.
Right.
Both of these, so that in effect, if I'm a geeky scientist, I'm not an engineer, but I've been accused of it. Well, okay, sometimes I am. We're Bayesian. We simply can't manage to process everything and there are various bottlenecks. So we do an awful lot essentially on autopilot. We just say, here's our prediction from the past, and we don't bother to change it. But
Right.
the idea was just that it produced a disconnect between sort of your past experience and the way you were experiencing things now. And I'm just struck by whether, in fact, is that part of the reason that different people may experience what we think of the same thing differently?
You mean your emotions differently?
Yeah, or even the description of it. I mean, it's just.
Well, I think what you're describing sounds to me like what I mean when I talk about automatization.
Yeah.
That things are put on automatic pilot when they're overlearned and familiar and comfortable, and we don't have to attend to them because we're able to split our attention in such a way that we can take care of that while listening to the radio or attending to something else. And it's one of the things, again, that I think we poorly understand about how the brain works. And it may be, if there is a reason, it may be the reason that consciousness exists, that allows us to focus attention and automate other behaviors that are adaptive in that environment.
So the other question thing, this question of what we experience in reactions. I mean, just sort of remark that I think, if the lion comes or something, I mean, there are times when we react to something and it's only after we've reacted that we feel it. In other words,
Right. Yeah, in the moment, it's maladaptive to fall apart in front of a lion. It's better to climb a tree or run away or whatever. Right.
But it was just fascinating. I mean, some long time ago at one of these meetings, more a physicist like me, thinking a little bit about biology, someone asked what was consciousness, and I thought that any system that was sufficiently large would acquire consciousness.
Does that include my dog?
I think they would say yes. I mean, I don't know, but I think that I was going to ask you that. I was leading up to that.
I don't know. I mean, I'm utterly convinced that my dog is conscious.
Yeah.
No.
I'm as convinced of that as I am that my kids are conscious.
They're sentient beings.
Maybe more so.
Absolutely.
Okay, I just want to say one word in defense of engineers. Without engineers, we wouldn't be doing this right now.
This is true.
True.
A lot of other things.
I don't think psychologists would have ever invented this system.
Exactly.
Well, yeah, I
Question about memory and before 6. There are things that I know that I remembered once, and I'm not sure that I still remember them, or I just remember what the memory was when I didn't remember it. Like I have a memory of my sister's a year older of going to her bed and announcing to her that it was her 5th birthday. And I remember describing that, and I'm not sure now if what I remember is describing it or the actual event.
Well, you're intuitively understanding what cognitive science is saying is true, that we reconstruct.
Yep.
We have this illusion that when we remember something, it's like a one-to-one correspondence. Remember exact. That's not the way the brain works at all. The brain reconstructs things, and it reconstructs some things more accurately than others. It reconstructs things that we attend to more accurately than things we don't attend to. Fortunately for most of us, most of the time, it doesn't matter whether it's a real memory or something that people told us about after the event. But in spite of all that, it seems to work most of the time.
But I disagree a little bit, no more than a little bit. Can you hear me?
Yeah.
Okay, thank you. I have a very edible memory. When I was about 3.5 years old, my father came in home from work. My mother was sitting at the table, and I was sitting at my little tiny flat table, a little chair. My father came in and said, "How's my favorite girl today?" And he looked at me and not my mother. And I remember that so vividly. I think I had competition with my mother early on. And there was no picture. I couldn't have invented it. I also remember at 3 years old going outside, and all around the sidewalk, there were all sorts of ants crawling around. And I screamed because I didn't want to walk on the ants. And of course, there's no picture of that either. So I think I remember from at least 3 years old. And I'm sure I'm right.
I'm sure
Well,
you're
most
right.
people are.
And I concur with you. I have distinct memories of the places, etc., things that I haven't talked about necessarily from the time when we lived in Dehradun. And I know we moved out of it when I was, before I was 3.
Yeah.
So I remember distinct events and some places and images that I have of where I was. One scene is about a snake. Well, I can understand why that would suddenly, stay with me. And I was carrying a little kerosene lamp, walking and suddenly seeing this snake on the stairs. And
If you're interested in this topic, I would encourage you to get the book by Loftus on memory.
okay,
I have a question.
It's the most sophisticated discussion I know of. Yeah, Neil.
I have a question that's off the subject you've been talking about, but to me it's fascinating. When I was in college, I took a course in sociology, and one day the professor couldn't be there, so he asked a psychologist to speak to us that day. He gave us a general view of psychology. He went away. I never saw him again. So I never got a chance to ask him my question, which was, what did you mean when you told us that all thinking is done in words? Is that true?
There is a school of psychologists who believe that, but there are a lot of people who don't also.
I have a very hard time believing you don't sometimes think in visual or graphic, something different.
Well, not only that, there are people who've had damage to the linguistic parts of your brain, what's called Wernicke's area, which is over here. And those people still are able to engage in things like playing chess, fairly complex games or interactions with other people.
So I shouldn't worry about that. It's just one of those.
Yeah.
Not everybody would say that. Thanks.
Can
I also confirm a memory. My brother got home from school the first day, and I had to be about 3. Because I mean, that's one of those memories where you can work it out.
Yeah.
He had to be some age, and I had to be some age. So it was about 3.
I think Booker Morey's had his hand up for a while.
Oh, thanks.
This is going to be the last question, guys. The last question.
This will be a fun one. Going back to the disconnect that you described between the person that showed no outward reaction to his wife screwing his best friend,
right,
and the biological reaction that were able to measure. I knew a psychologist, I guess he was, whose job was to interview police applicants. And he was looking for things like racism, anger management, predilection toward violence, et cetera, et cetera. I would imagine that 1 or 2 sessions really wouldn't do anything to ferret those things out when the applicant already knows what the answers ought to be. Is that?
It's a mixed bag. I think there are some people who you can pick this sort of thing up pretty quickly, particularly if they're honest with you about, have you ever gotten in a bar fight? What punches your buttons? Tell me about, the neighbor who drives you crazy. And you get this nonverbal manifestation. Well, that son of a bitch did this, So, well, that tells me this guy's got buttons that are easily punched. And he may not be a good candidate for this kind of work.
Okay, thank you.
So, this was great, Mark. Really, it's nice to have, you're actually appreciating the science and the historians and the people that are doing the work. It sounds like there's going to be more on this subject, particularly when it gets a little more scientific, when they begin to be able to pull more information out scientifically. Next week, we will not have science for the board. We're probably going to go to a summer schedule that may be once a month. Our speakers have done a lot of speaking and the weather's getting good. I will take suggestions on anything that we might want to do going forward. If there's any forums or discussion groups or anything like that we could do. But right now I don't have enough speakers to have a regular, weekly session right now. I think probably some of that's the weather, some of that's that things are opening up. But I know that there could be some good ones.
May I say that to me, once a week is an enormously ambitious schedule. To do this once a week is way too much. You're 2 dozen or 3 dozen people. It should be once a month, maybe.
Yeah.
Great. I've been enjoying once a week.
Me too. Yeah.
I would like that to continue, and I'll have to talk to you, Bruce, about doing a talk.
Yeah, I do once a week if you know, if there was, you know, it's really come up organically. I mean, you people have all volunteered, and I've had enough to do once a week, and it hasn't been a burden for me because, you know, I enjoy doing this.
That's great.
Yeah,
Bruce, what about one of those short, you know, having 2 or 3 short presentations?
sure, and we'll do that, but I think we'll do it once a month for a couple of months, and then if when things start to if things start to gel again, we can have more than one. You know,
Okay.
for sure we'll do some of those.
I
Well,
would,
we appreciate you doing this, Bruce. You guys putting this together.
Yeah.
Yeah, it's
Bruce, I would
awesome. I mean, you know, I haven't worked with a group as of thinkers like this in my life. I don't think, you know, in this kind of a forum, and maybe it's because it's Zoom and we get people from all over the place that sort of have a similar mindset.
yeah. The other format that you might consider is a subject upon which there are 2 different points of view, and we could put the 2 people up at the same time to try and
With gloves or just bare knuckles?
Yeah. Well, how about we get you, Booker? How about if we have you and was this Booker? Who was just talking there?
I don't, maybe I would say
David.
David.
Oh, David, not David Dunning though. A different David.
No, David the engineer.
Okay. I don't know who I put up. I put you up against John Miller, and then you'll have a heck of a time. Oh boy. Okay. Well, anyway, we will be sending out a notice when we get the next talk. Please send me your information. If you want to do a talk, just let me know by email or give me a phone, give me a call if you have my phone number. Do you people have my phone number?
I don't have it. What is it?
It's 503
Yep.
919
Okay.
0480.
Okay.
Put it in the chat or something, because it's hard to remember that many digits.
Yeah.
Yeah.
I wrote it on a piece
Here
of
we go.
paper with a pen.
Now I have a piece of paper. I'm ready.
3
Okay.
I know it's
thank
good.
I'm old.
80.
some people just prefer when phone numbers with 3 digits.
When was that?
I still remember Dave's number when we were dating and it started with a word. It was still,
Yeah.
and then and there was no area code nonsense. I mean, you didn't have to dial 10 numbers because you really dialed. And you have a party line.
Oh, you must have been a great date, Judy. Oh boy, a bit challenge for David. Good job, David. You tamed the wild one, or she tamed you. I'm not sure.
I don't know
Right.
about timing, but in recent years, Judy has displayed interest in so many areas that I don't think she was previously interested in.
No,
So she has just grown intellectually over the last few years tremendously. I'm very impressed.
I almost failed physics in college, and yet now I've given talks on physics and on the universe, and you know, that's how you develop. That's how your brain keeps expanding. So
Yeah.
okay,
Well,
thank you so much. This was very interesting. Enjoyed it.
Okay. So we'll be in touch, everybody, and I think we're going to call it a day. This is going to be one of the longest tapes we've had, and it was a really good session. So thank you. Bye bye.
Thank you.
Thank you.
It's good.